everyone. Welcome to the Mailman Grand Rounds. Thank you for joining us. Before I get started introducing our esteemed presenter today, I wanted to just touch base on one housekeeping point. Those of you seeking continuing education, please make sure that you're here until the very end and that you complete the evaluation at the end in order to get credit for being here. All right, so it is my absolute pleasure to introduce our presenter today, Dr. Rahil Briggs. She's the National Director of HealthySteps, a program of 0 to 3. Since 2018, she has overseen the dramatic growth of HealthySteps to over 260 sites across the country, reaching approximately 405,000 children and families as of 2023. She's responsible for all aspects of the program's operations, financial sustainability, evaluation and research, policy, model enhancements, and site professional development and training. She comes to this role after a successful career at Montefiore in New York, where she grew the HealthySteps footprint from 1 to 21 practices, serving over 30,000 children annually. Additionally, Dr. Briggs is the founder and former director of Pediatric Behavioral Health Services at Montefiore, one of the largest integrated pediatric behavioral health services in the nation. The Academic Pediatric Association awarded her for this work with the 2018 Healthcare Delivery Award. Dr. Briggs is the editor of the Integrated Early Childhood Behavioral Health in Primary Care, published by Springer in 2016. She's clinical professor of pediatrics and psychiatry at Albert Einstein College of Medicine and completed her undergraduate work at Duke University and her doctoral work at New York University. It is my pleasure to introduce Dr. Briggs. Thank you so much for being here with us.
Thank you so much, Maite, for that lovely introduction, and good afternoon to everybody. Thank you all for the invitation to join you this afternoon. I'll be speaking about prevention and promotion basically today, and how we can really leverage the power of pediatric primary care. Side note, pediatrics means family medicine, nurse practitioners, anybody who delivers well child visits to young children. And if you hear nothing else, if you remember nothing else, if you can think of nothing else, please remember this. What's predictable is preventable. And we have both the bench science and the implementation science to know what to do to get this right for babies, toddlers, and their families. So as Maite said, you have to stay to the end to get your CEs, but that hopefully is a key piece of what you hear from me and this work. All right, so to give you a preview of what I will cover today, here's the agenda. We'll talk about this idea of early prevention and promotion and why it matters so much to get it right in these early years. Talk about that pediatric setting and why team-based dyadic care is the way to manage these issues that come up. Go a little outside the pediatric setting and talk about the real systems transformations that need to occur to get this right, and then just give you a snapshot of the HealthySteps network, both nationally and in Miami and Florida. All right, so on the early prevention and promotion side, it is remarkable when you think about brain growth in these early months and early years. Everyone throws out this data point that 1 million new connections every second. It's a hard scale to think about. But the most important thing to know is that the brain is growing faster during these first 3 years of life than at any later point in life. And there's this real use it or lose it thing that's going on. So neural circuits that are frequently being used for things like attention and memory and language are getting solidified. And on the other hand, if there are neural circuits that aren't getting used, for example, Japanese speaking babies who just never hear English spoken language, they may lose the ability to hear certain sounds in that language. So those neural circuits get pruned away. You hear folks talk about infant brain development as plastic, but what does that really mean? It means that it is super receptive and bendy, right? So it's disproportionately receptive to input, that infant and early childhood brain. And that could mean good or bad. I often used to say to families that I worked with that there's a little recording device in that brain that is always on. The only choices we get is what that recording device actually records, right? So we can influence what's getting recorded, but not whether it's on or off. It is really like building the foundation of a house. If you get this right in the early years, you have built a system that can withstand some storms. And if you don't, then there's lots of work to get done to catch up, right? This slide is a little bit difficult to see visually, but on the left-hand side of this time, we're talking about months, and on the right-hand side, years. Oops, sorry. Don't know how it jumped forward. Wanted to jump forward to the years part. But if you look at where that box is, that is the first 2 years of life. So post-birth, up until age 2, you see this extraordinary development of neuronal connections. Really a critical period in terms of some of these connections being made. Again, get it right in these early years, and you get it right. If, on the other hand, during these early years, this slide is a data set from Barth and colleagues, they looked at a set of children, all of whom had been referred to child welfare, So we knew that these children had pretty significant risk factors going on for them. And what these data showed, really remarkable for those of us thinking about development, developmental disabilities, and where some of those come from. Sometimes they come from what happens in those first 3 years in terms of brain development. This slide shows that if a child faced 7 risk factors in their first 3 years of life, 100% of those kids were diagnosed with a developmental delay. Again, if you had 7 risk factors in the first 3 years of your life, 100% of those kids were diagnosed with a developmental delay. And you see that sort of graded relationship, if you will, on the slide. When I was working with residents, I'd say things to them like, listen, this is a finite system, the early childhood brain. And so if I've got to spend all my time thinking about safety or managing hunger or managing fear, that's not leaving a lot of time to use that brain to learn ABCs, right? And so you start to understand a little bit about these striking results and the cumulative effect of trauma and subsequent developmental delay. So if we accept that this is a critically important period of brain development, and hopefully in 5 minutes you've accepted that, the good news is that we know what works. To encourage that really strong foundation of healthy brain development and to moderate any potential negative effects of trauma, of risk, of poverty, we start with families. No surprise there. Babies don't exist in a vacuum. Winnicott very famously said there's no such thing as a baby, by which, of course, he just meant that babies can't exist on their own. And the science has really underscored what families have known for a long time, that positive relationships and emotionally nourishing relationships with caregivers are actually one of the very most important things for prevention, promotion, development, behavior, and the whole thing. So this graphic is a somewhat busy graphic with a lot of math on a Friday afternoon, but actually not really. So it's talking about self-regulation, this graphic. But the reason that I included it is because it's actually quite simple. If you want to get to the regulated child, which is the pinkish reddish on my screen, you'll see that it doesn't really matter where the child starts. It matters where the adult is. If you want to know how the child is doing, look at the adult, right? So in addition to being a disproportionately important time of brain development, early childhood is also, unfortunately, a time of disproportionate poverty. Our country's home to about 11 million babies, and as many as 39% of them, as you see on this slide, live in households with incomes less than twice the federal poverty line. And why do less than twice? Because the federal poverty line, my friends, is less than $30,000 for a family of 4. So this is just $60,000 for a family of 4. And so these are families that are looking at economic disadvantage and increasing the likelihood that they're going to face adverse childhood experiences, more risk, more stress, more trauma. And in Florida, as you can see, that number is even higher at about 43% of babies and families in low income. If you look at true poverty, the way it's defined in this country, and again, it's like 29,000 and change for a family of 4. In Miami, that doesn't go far. So you're looking at the very end of that income spectrum. You see that it's almost 20% of babies, it's 19% in both the country and in Florida, who are living in abject poverty, 29,000 and change for a family of 4. And then when you look at how that breaks down by race and by ethnicity, you see that babies of color are disproportionately feeling the effects of poverty in the country and in Florida. A higher percentage of babies of color live in poverty compared to white babies. In Florida, you see those numbers that a baby who is Black is more than twice as likely to live in poverty as a white baby. And these numbers are shocking. They reflect policy choices. They reflect decisions that have been made for a long time, and they should all be in the single digits. I think we can agree on that. All right, so not to get you too down on this Friday, let's start to talk about solutions and what can we do if we accept that this is a disproportionately important time of brain development, but that there's also disproportionate risk in poverty. What can we do about it? Is poverty a life sentence? Absolutely not. I am a personal product of that truth, and I'm sure many of you are as well. So if families are strong, and we do everything we can to help families be strong, they can serve as amazingly powerful sort of buffers against the otherwise really critical effects of poverty. They can moderate the effects, they can buffer the effects. And so then you say to yourself, all right, if families are my unit of intervention, where do I find said families? And as we've been talking about promotion and prevention, where do I find them before there's a problem? Before they get referred to a mental health clinic or a developmental disabilities clinic, where do I find them before, since brain development is so plastic and I can really get in there and stop some of these things from even happening? Well, the good news for us at Healthy Steps and for other folks working within the pediatric space is they're in the pediatric office. Turns out babies don't come to the doctor by themselves. They don't come on the school bus. They don't get dropped off. They come with parents and caregivers. And it is our country's only almost universal point of access. I say almost because not everybody comes for those well-child visits, but we're seeing upwards of 90% of families connected to a pediatric primary care provider. While the last 4 or 5 years have done damage, and maybe even the last 8 years have done damage to trust in science writ large, families still trust their pediatric provider. They trust the pediatric provider to give advice about development, behavior, growth, illness, wellness. And I can say this as a child psychologist, having started my career actually in the mental health system. Pediatrics is remarkably non-stigmatizing. I'd go one step further than what it says on the slide and say it's positively stigmatized. I mean, you're a good parent if you take your child to the pediatrician. And also different than some of our subspecialty referral clinics like mental health or developmental, they keep coming back. You know, there are 12 to 13 well-child visits within the first 3 years of life, and 7 of those happen within the first year alone. So you have this repeated, frequent access to build trust, to partner with families, and to get it right for children. However, pediatricians have about 15 minutes for a well child visit, which you know if you're a pediatrician or you've taken your child to the pediatrician. And in that 15 minutes, they're supposed to do approximately everything under the sun, from vaccinations to are you growing to, fluoride in the water and bicycle helmets and how are you, mom and dad. It's a pretty impossibly long checklist. So what we do in Healthy Steps and what other programs like Dulce or VIP or other sort of integrated early childhood pediatric primary care programs do is they expand the care team. And we are really adding a Healthy Steps specialist who is an expert in child development on behavioral health prevention and promotion to work alongside that pediatric primary care provider. So it takes a village no matter where we are. Let me stop for a minute and talk to you about one of our moms in the Healthy Steps program who has given us permission to share her story. And you'll forgive me as I read it because I want to get it right and tell you exactly what happened. Anna was new to the Bronx and primarily spoke Spanish. She and her toddler twins had been living in a relative's living room. Eventually were asked to leave. It was just too crowded. She didn't know where to go and spent the night in a nearby park with toddler twins. The very next day, after spending the night in the park, she attended the kids' well child visits. She told her Healthy Steps specialist, "This is all I know, and it's the only place that I really feel safe and accepted." So after sleeping on the park bench, she went to her primary care practice and her Healthy Steps team. Dayanira, who was part of the team, found Anna a family shelter immediately that night and connected her to a number of resources in the community. We learned that one of the twins, this happened at Montefiore when I was there, so we learned that one of the twins had autism and made sure that he got referred to early intervention. He's since then received applied behavioral analysis, ABA, the evidence-based autism therapy. Anna is working, has transportation, has her green card, and her other children are in school. So I share that with you at the top of our time together because it speaks to what happens when you have a trusted system and you have enough people in that system who know families and can respond to what's happening and what's coming up in the moment. And really, Dayanira, no surprise, spent the entire day with Anna and her family once learning that this had gone on. So let's just walk through our model, Healthy Steps. It's not the only model of integrating into pediatric primary care practice. As I mentioned, there's VIP, which actually is called something else now, like Play Learn VIP, I think, but I'll get that right. And Dulce, they take a similar approach, but here are our 8 core components. You can do other things, but as the Healthy Steps folks know in this meeting, these are the 8 core components that you must do as this is an evidence-based model. I'm not going to go through all 8 of these, but I do want to highlight a couple of them that I think are really critical for transforming this pediatric practice setting. Team-based care, right? So you see in the bottom right corner, ongoing preventive team-based well child visits, team-based care, and care coordination and systems navigation in the upper right. Both of those really help us stop relying solely on the pediatrician and the office and leveraging the full team, leveraging that platform to bring in the community and connect with the community, right? And the model, like I said, is structured to make sure that all of the 280 plus sites at this point are executing these necessary 8 core components because we know that the research and the evidence shows impacts, but they can also adapt the model for their unique sort of settings. So maybe home visits are included, or maybe family support groups might be included. In addition to having our 8 core components, we have 3 tiers of service delivery. And this tiered approach really helps us to be both population-based, so tier 1 is everyone in the practice, birth through 3, and risk stratified, because it doesn't make sense to give all families exactly the same thing. Some families need a little bit and some families need more, and that changes from time to time. So you see here the 3 tiers of Healthy Steps. In tier 1, requiring universal screening for child concerns, including autism, behavior, and development. For family concerns, including parental depression and social determinants of health, and just a family support line so families can connect with someone as needed when things pop up. Moving a little bit up that risk stratification, we see tier 2, which in addition to receiving everything in tier 1, these families have what I like to call the lightest of pink risk flags. These are not red flags. These aren't big diagnoses. This is not, oh gosh, there's something really wrong. It's the earliest possible warning signs, because what's predictable is preventable, right? And so for these families, they're receiving child behavior and development consultations, quick, maybe 1, 2, 3 sessions to just get that kid sleeping, because that'll improve the whole family's life, or to figure out sort of what's going on in terms of language exposure and reading and why this kid isn't talking quite as much as we'd expect. As I mentioned in the previous slide, care coordination and systems navigation is the next core component. So for every single referral that leaves that pediatric practice, instead of dying some long, slow death in some dark box that we don't know what happened, they are successful referrals. So for example, one of our sites in Washington, D.C. quadrupled their early intervention referral success rate after adding Healthy Steps. Core components 6 and 7 are a focus on positive parenting guidance, early learning resources. And then finally, tier 3 is the top of that risk stratification. Again, hopefully no child diagnoses yet, but maybe this is where you might see family diagnoses, parents with mental health concerns or substance use issues, maybe some congenital concerns from the baby, a NICU stay or a very low birth weight. Families that we know from the literature might be exposed to more negative outcomes in terms of the development and well-being of their child. And for these families, they get everything in tiers 1 and 2, plus the Healthy Steps specialist co-manages each and every one of those 13 well child visits. So that when Anna says, I've been in the park bench, where do I go? I know the Anita and the team there, that's where I'll go because I've known these people. I've talked a lot about promotion and prevention and how that then is on a continuum to treatment, but really want to highlight some of the particularly important aspects of promotion and prevention in the behavioral health space. So this slide talks about secure attachment, focusing on the secure attachment between babies and their caregivers, because there's a huge literature saying how important that is. Reducing toxic stress. Toxic stress being that unrelenting stress that really starts to wear down the body, the brain, and the ability for healthy growth and development. And that can be on the kid side or the caregiver side. Treating the patient in the primary care practice as a family, right? You don't tell the 6-month-old how to sleep train themselves. And if you do, you'll be working at it for a little while. On the prevention side, I talked about those light pink risk flags, right? So those really early warning signs that something's not perfect, because this is such a disproportionately important time to get it to be perfect. We want to really react when it's not perfect. And then really refer to other services like the Mailman Center, like other services in the community, when the baby might need something that's outside the scope of the pediatric practice. And of course, making sure that treatment is coordinated and happens. So I mentioned a couple of times that this is an evidence-based program. There's a QR code here that will give you a much more comprehensive summary, and we'll make sure you get these slides. But we think a lot about equity and health equity. And each one of these 6 areas on the slide that you're looking at is an area where we know from the literature there are real disparities, especially for children of color and children who are growing up in families with low incomes. So in each and every one of these 6 areas, we know the data really cut and look much worse for children of color and children growing up in families with low incomes. We also know that our data and our findings show that we can close those health disparity gaps. So we know that when we successfully implement team-based care, do so in an evidence-based way at Fidelity, focus on these babies and toddlers, because the brain is, remember, 1 million neural connections every second. So it's like the most rapid time of brain development. Let's get it right. We show that we can close those disparity gaps, prevent those problems from happening in the first place. Healthy families have healthy babies. So I will dive into a couple of areas of the evidence on the next couple of slides a bit more deeply, but remember there is that QR code and you can get the summary. So let's start with just making sure kids show up at the pediatric practice, because great, you have this team-based care model and all these wonderful folks waiting to do everything that's needed, but if you don't make it there in the first place, then that's not very helpful. You won't be surprised to know that there are real differences in terms of children with Medicaid coverage and children with commercial insurance, and the likelihood that they show up to the pediatrician. It's about a 10% gap. That's a problem. We tackle that problem and make sure that we're closing that gap. And through lots and lots of data here, that's, we can make sure that you have all of these references showing that children are more likely to attend all of the first, recommended well-child visits. They're more likely to see the same provider. That's what's meant by continuity of care, that they see the same pediatrician over and over again. We are, as I said, tackling that disparity based on income and insurance coverage in terms of actually attending the well-child visits. And you can see from an exciting new piece of work that's in publication right now that Black and Hispanic HealthySteps children with Medicaid received more well-child visits and were more likely to see the same provider than a control sample. Well-child visits, in addition to leading to team-based care like HealthySteps and behavioral health and development, also lead to vaccinations. We know how critical those are. I don't need to go into that. HealthySteps helping to make sure that vaccinations happen. So once we've got you there in the pediatric practice, then how can we make sure that we're screening and then connecting you to services in the community to the extent that that's what's needed? I already noted the amazing outcomes at Children's National in DC, where they basically quadrupled their rate of successful early intervention referral. Also at Montefiore, where I used to work, we looked at referrals writ large. So not just early intervention referrals, but also parental mental health referrals or housing referrals or what have you, and really showed an extraordinarily high referral success rate. I think it was upwards of 90% of the referrals were successful. We see that HealthySteps children are more likely to receive EI services, more likely even when we look at different racial and ethnic groups. And so in essence, making sure that kids get screened equitably, making sure that they get successfully connected to services, and that families do as well. And then let's look at our final slide on the findings on social emotional development. Social emotional development, I think, really being a key foundation for mental health and for developmental well-being. Right? The more that we learn about social emotional development, realizing how critical it really is. So we need to screen for social emotional development, despite there not yet being a AAP mandate for that. We need to make sure that everyone understands how important this area is, and then do the interventions necessary to make sure that children look better. So you see a number of different data points here to suggest that each of those things are happening. All right, so that's sort of the work in the pediatric practice. And I want to spend about the next 10 and a bit minutes, but really leaving time for questions, and hopefully you're putting them in the chat as things are coming up, on the systems transformation piece. I mentioned that you can do all this in the pediatric setting, but it's more than that. It's about transforming the system so that we can really create a different foundation. So what does that look like? I want to focus on 3 important areas that we have focused on at the Healthy Steps National Office, but that are key for any sort of systems transformation. The first is electronic health records. Quite simply, they're not set up for this. The second is workforce. You all know that we have a real problem in terms of workforce, early childhood, prevention-focused, mental health, developmental folks. And the third is sustainability, because we have a healthcare system that pays for problems, not prevention, right? So let me go through each one of these. Electronic health records. If you work in primary care, you know this, and I don't need to tell you. If you don't, you may know this from being a patient, but they're a mess. And on the other hand, they drive clinical care. They drive billing, they drive care coordination, they drive communication with patients. You get, alerts. And if you think they're bad in general, pediatric electronic health records are especially anemic, and that's being polite about it. So the way that EHRs get created is like a lot in healthcare, folks go to the big money makers in a system. So that might be surgery or oncology or cardiology, and build out really exciting templates for those specialties. And then the pediatric primary care template is like this, it's got a few things on it, but not a lot of bells and not a lot of whistles. And they say, well, we'll just give you the foundation so that you can customize it to really work for your practice. Yes, but if you want to know who's at the end of the line on EHR customization, pediatrics, right? So it doesn't quite work. When we started to try to tackle this, because it matters for clinical care, care coordination, billing, and data, you can't really be an evidence-based program if you're not checking fidelity to your model, and you can't check fidelity to the model without good data. So we spoke to our colleagues at the American Academy of Pediatrics on this, and they said, you know what, it's going to take an act of Congress to change this. Thankfully, as it's pretty hard to get acts through Congress these days, we found another route. And so we have partnered with Epic. Epic is the largest EHR company in the country, covering about 50% of pediatric platforms, And we created a playbook there. You see the QR code where you can find out more information. But essentially, it's changing the pediatric template so that now you can document all these screening results for children and their caregivers. What an idea. You can document a closed loop referral so you know what happened with that early intervention referral that you set out. And you can make sure that care is better. So it's a good start, and we have more to do because not everybody's on Epic and things cost money, but really excited about this first attempt to really improve the EHR platform for children and families. Workforce. I don't need to tell all of you, as there are many psychologists and other folks in this audience, but things changed with COVID, right? So we've always had a behavioral health workforce challenge, as far as I can remember. There's never been enough social workers, psychologists, psychiatrists, developmental specialists for children. And then COVID hits, and suddenly mental health becomes really accessible and acceptable. And so I can either go into a healthcare setting during COVID and face a pandemic and bring that home to my family and maybe make, I don't know how much everyone makes, but 70 grand a year, 90 grand a year. Or I can sit at my kitchen table, take my kid to school in the morning, pick them up from the afternoon, and make hundreds of dollars an hour doing behavioral health. So a dramatic shift occurred from that in-person focus to a much more lucrative telehealth piece. Another piece of the workforce challenge is that we're a population health-based program, and we have a North Star goal of reaching at least 1 million children by 2032. Well, you're not going to do that with only licensed child psychologists as your workforce, right? So really expanding the workforce and thinking about community health workers and patient navigators and social workers and early childhood specialists and all the people that it takes to get this done. But in recognition that all those folks don't share one training approach, right? We created what we call the Healthy Step Specialist competencies, and you see them here on the slide. Really making sure that across the country, across this broad range of Healthy Step specialists, there is a unifying structure and folks are speaking the same language. The competencies look at dispositions, knowledge, and skills. And these are free and available on the website. And it's not just about Healthy Steps. It's about any sort of integrated early childhood development and behavioral health prevention and promotion role. But you see these 3 areas on the screen. It's the Healthy Step Specialist, the caregiver-child relationship, and then the contexts that you're working within in terms of communities and systems. And you see the focus both on dispositions, so how a Healthy Step Specialist really is with families and colleagues, and really areas of knowledge and skills, what they know and how can they fill the role. So in our systems transformation section, we've talked about the EHR, we've talked about the workforce issue, and now we'll talk about sustainability. This could be an hour in and of itself, but I'll make sure that it's not. Basically, we have a healthcare system that pays for diagnoses, right? So if you have a behavioral health diagnosis or a developmental diagnosis, services get paid on that diagnosis. But everything that I've been hoping to describe to you is about prevention and keeping those children from ever having a diagnosis in the first place, because what's predictable is preventable, but it's not necessarily paid for, right? So we pay for diagnoses, we focus on short-term savings opportunities. Babies don't cost any money, they're low cost, don't worry about them. Let's focus on our high-cost adults. And I'm not sure that everyone at every state Medicaid office understands as much as we'd like them to about early brain science and the importance of really getting it right. Had I come and talked to you at Maite's invitation, again, thank you, a few years ago, I would have probably stopped here and said, this is a problem. We all collectively need to work on it. Let's get to work. But thankfully, I can share with you some solutions and some signs of progress. On both the federal and at the state level, over the last few years, really, we have partnered with a wonderful coalition of folks, again, both at the federal level and at local state levels, to bring change to payment for prevention. Yay! That QR code will take you to a huge section of sustainability resources, yes, applicable to Healthy Steps, but also applicable to other systems, other services, anyone who's trying to get this done. This is a busy slide, but I'll walk through it a little bit for you. All right, on the federal side, what they've basically done is large grant programs focused on the community health centers. So community health centers, sometimes called federally qualified health centers, are those safety net health centers in the communities where I know some of you work, where we really practice a safety net approach to care. And there was millions and millions of dollars, and we hope for even more millions next year, to embed early childhood developmental specialists in those community health centers. Should sound familiar. There was a second big federal grant, again, many tens of millions of dollars, to set up what they call TPEC, Transforming Pediatrics for Early Childhood. And those are state level systems to really think about the pediatric platform as the transformation vehicle in early childhood. And so that's been a significant federal support as well. Both of those happened in 2022 and 2023 and are the first of their kind federal investments in the pediatric primary care space for young children. So very exciting. At the state level, we've worked with wonderful partners in states where we think there is a ripe, eager excitement to get this right. and have some wonderful payment solutions that have popped up over the last few years. California is a great example where they are now paying a behavioral health dyadic benefit. So there's a health benefit, now there's a behavioral health benefit. Like, think about it for a minute. You can go to the pediatrician without a diagnosis for a well child visit, and that gets paid, but you can't go without a diagnosis for a behavioral health well child visit and get that paid. We pay for prevention at the dentist. We pay for prevention every time you go to get your mammogram. You should go. We pay for prevention all the time, but not where it might make the most difference in early childhood. So California changing that. Maryland doing something very geniusly simple, just saying, okay, for every practice with HealthySteps, if you're at Fidelity, we'll pay you an additional $15 for every single visit for every kid birth through 3. That's our priority population, children birth through 3. And so it's a sick visit, it's a well visit, you get $15 extra on it, that pays for HealthySteps. Simple, easy. And in other places, Arkansas, Massachusetts, New Jersey, New York, seeing solutions about maybe these alternative payment methodologies, an additional chunk on top of what we would have paid you, maybe a huge grant through the Office of Mental Health, or maybe just new codes opening up that finally we're paying for prevention on the behavioral health and the developmental side. All right, I want to spend the last little bit of my time with you talking about the HealthySteps National Network, but also telling you a little bit more about the great work that's going on in your corner of the world in South Florida. So the national numbers, Maita talked about our 2023 numbers. Here's a little bit of an update with the first few months of 2024. So as of April, last month, we have 279 sites across 24 states, Washington, D.C., and Germany. You say, how Germany? We have a wonderful partnership with the Department of Defense, really recognizing that those children and families are under specific stress and strain, repeated deployments, poverty. And so it's through our Department of Defense collaboration that we reach those kids in Germany. We're seeing remarkable growth year over year. We saw growth through COVID. There was no slowing down of this. We are currently reaching almost 450,000 kids. And our goal, as I've said, is to reach 1 million by 2032. So we're almost halfway there, but growth is on track to reach that target. So Florida. HealthySteps in Florida, there are 17 sites. And as I was telling Maita before we got started, there may be another one coming on board. Right now, reaching over 18,000 children birth through 3. Really concentrated in the Miami area, in the West Palm Beach area, and over in Hillsborough County in Tampa. So in Miami, with huge thanks to the Children's Trust, who's been a very consistent and constant funding partner. There has been some amazing work going on. I'll embarrass some of you who are on this call right now with this picture. I took it, so I get to include it. You see the HealthySteps team, and they have been serving families in 3 practices that you see here, Desai, Kendall, and Jackson. And they've made a big switch. They only used to do the tier 3 model, the highest need kids. So remember, in that tiered model, they were just focusing on tier 3. Recently, though, they've added in that tier 1 and that tier 2. And I think it's been really exciting. They've gone from serving, I think, 400 families to serving about 1,500 families just by adding that tier 1 and that tier 2. And that's not including families that just got a screening, right? Which has been thousands of screens that you can see here on the screen. So, sorry, screen in the both in one sentence using 2 different ways, but you know what I mean. So since October of last year through March of this year, there have been 3,500 plus screening tools administered in these 3 practices at And you see that 10% of those kids popped up on that screening with a concern about a developmental delay. a small handful of mothers, but every mother counts, with elevated depression screening. And then a really significant chunk, no surprise to those of us who know what cost of living has been like in Miami recently, with issues related to social determinants of health, housing insecurity, food insecurity, right? And I think it's pretty remarkable, the growth that has happened at where the addition of these tiers, tier 1 and tier 2, has not just increased the number of families served, but I think, in speaking with Maita and her team, really helped to integrate better into the full pediatric practice. That this isn't just some grant-funded program over in the corner. That if we do our job right, as they're doing in this team and around the country, we're changing the promise of pediatric care. We are changing that universally accessed, trusted, repeatedly accessed platform, adding in the team-based care, doing it in a way that's both risk stratified and population-based, with 8 core components over 3 tiers, reaching every single child and family in the practice, making sure that things are going as perfectly as possible, because it is that disproportionately important period of early childhood brain development. All too often, we are seeing families with kids who are 3 or 4 or 5, and they've already gotten kicked out of preschool twice. They've already failed some other child setting. And finally, folks are saying, we got to get this kid into some services. And from where I sit, that's 3 or 4 or 5 years too late. I'll give you the best example of that I can offer. I was working with a family at Montefiore, and this baby was 18 months old and wasn't talking. And we all know that by 18 months, you want a few words, nothing fancy, but a few words at least. Didn't have any. I went into the well child visit and I met with the family and talked to Dad, who had brought in the baby. And Dad explained to me that he was working nights and his wife was working days, and he was taking care of this baby during the day. I said, well, hold on. If you're working in the night and taking care of the baby in the day, when are you sleeping? No, I just catch little naps here and there. All right, well, tell me what a typical day is like. So, well, you know, we're eating and we're just hanging out, and I play a lot of video games. I have my headphones on and I'm playing my video games. And I said, are you chatting with your son about what you're doing and what you're seeing? Well, no, Doc, why would I? He doesn't talk yet. And I said, well, he's going to learn how to talk because you're going to talk to him. That's the way he learns. And even just saying to this dad, can we do it for 5 minutes a day for the first week? And then can we up it to 2 times 5 minutes a day for the second week? And helping Dad to understand the power of him talking to this baby, helping the family understand the need to figure out a schedule that allowed for them to pay their bills, but also get some sleep. And this child, by his 2-year visit, was speaking up a storm and combining words and doing all the things that we want. That's the power of getting this right in the pediatric practice. So a huge thanks to all of you. Tried to leave a whole bunch of time for your questions and can go much deeper into any other aspect of this that would be helpful. But you see here the website, healthysteps.org, where a lot of those QR codes will take you, and then on social, things that you can find here as well. So I'm going to try to end the slideshow and hopefully, therefore, see bunches of faces. And hopefully Maita can help me in terms of questions that have come up in the chat or questions that you have, because you know this works so well and you know what would be of interest to your colleagues, and we can go from there.
We don't have any questions in the chat, but encouraging everyone who has a question to please unmute yourself.
Please do. It can be relatively informal. Unmute yourself, raise your hand the old-fashioned way or the Zoom way. And Maita, anything from your perspective that you think would be particularly helpful to dive a little bit deeper on or expand upon it, considering this audience?
Well, as I hear you talking, doing such a wonderful presentation on Healthy Steps, and I know we share our passion for this program and the wonderful impact that it has on families. One thought that I had was maternal health. And how that's also a component. I know you touched on it in something that we screen, and we after COVID has seen a big increase in terms of moms with postpartum depression and high levels of anxiety, other mental health concerns. And I'm just wondering from kind of your perspective at a national level, what you've seen or what you've heard when it comes to maternal health. Because we know that if mom is happy, baby's going to be happy. So we want to make sure the moms are okay.
Exactly. It's a great question. Thank you. The best part about pediatrics, from my perspective, again, is that they come with their parents. And I won't ask all of you the last time you went for your well visit or the last time you got your preventive health visit, but it's not always great, even for those of us who have resources and have good docs and have health insurance, right? So often, these children with significant risk factors that we're thinking about for tier 3 have families, have moms and dads with very significant risk factors who haven't been successfully connected with healthcare. You take Medicaid writ large and you see really pathetically low levels of moms who've given birth actually going to that 6-week postpartum visit, right? So they're not going to the 6-week postpartum visit, and then they're not establishing care on the adult medicine side of things. And the ability to practice a family-based approach to care, where you know that, like you said, if mom's happy or if dad's happy, then we have a good chance for baby to be happy, right? There's no health without mental health, and there's no child health or mental health without caregiver health or mental health, is a real game changer. So being able to assess for depression, a number of Healthy Steps sites are also assessing for parental anxiety. Those social determinants of health being key drivers of stress, of anxiety, etc. We have a number of Healthy Steps sites across the country that screen for adverse childhood experiences, or ACEs, really to reflect significant trauma that folks are experiencing or facing. And you'd be amazed. You think, well, it's a pediatric practice, like they're going there to get their child services. But once you have that trusting relationship, being that connector for the mom, the dad, the caregiver, the, grandma, whoever is really those key caregivers, being able to connect them back to the adult serving side of the system is a game changer. I cannot tell you how many people I've met who, through their child's pediatric visit with Healthy Steps, finally got mental health care for themselves for the first time. Because you could put a lot of things off, and then you have a baby, and then it all comes up, right? All those things that you needed and wanted to deal with. So getting therapy for the first time, getting connected to healthcare for really, in many cases, the first time, going to that postpartum check, getting connected to the dental care. Maita, one thing I didn't talk too much about in this presentation, but we've done a lot of return on investment work. And I can try to put something in the chat on that. But the return on investment work looks at when you intervene in this way and you tackle these things, do you save any money? Right? Because that's what people want to know. Some people want to just do it because it's the right thing to do for kids, but some people want you to save money. And the cost savings are very significant. And most of the cost savings come because of the caregiver and the parent, right? Because that's where the money is spent. So when we can tackle smoking cessation in parents or caregivers, or tackle interpersonal violence with parents and caregivers, or get them back to their primary care practice. That's saving significant amounts of money, so that I think it's about 163% year-over-year cost savings that we're seeing based on the Healthy Steps model. But I'll go over here to my other screen and pull that up and put it in the chat for folks. But thank you for highlighting that piece.
Dr. Armstrong?
Hi, I'm Danny Armstrong, Director of the Mailman Center. I think we may have met when I did a site visit at Einstein Montefiore a few years ago. Wonderful work that you're doing here. I guess one of it brings up a whole host of issues. One, we're really struggling with the issue of access, and workforce is the major access. I've shared with our team here in 1999. I've worked with a team with David Satcher on the Surgeon General's report on children's mental health, and at that time the ratio of children who met a DSM diagnosis to providers of any ilk in every discipline that were involved with children was about 900 to 1. During COVID, in some areas, that number has gotten up to as high as 1,750 to 1. It's come down to about 1,000, 1,100 as we're getting out of COVID. That your point about developing new models involves training. It involves a workforce that we can pay for. We're looking at a lot of things right now, and are there opportunities to use technology? Is there a role for AI potentially in helping to meet some of these needs? Because we're leaving a lot of children underserved in our traditional models. The other piece is trying to figure out how to connect major programs that are all doing a good thing in all the areas that you talk about. When I look at where we are with Mailman Center, we've got a phenomenal Healthy Steps program. We have a Jumpstart program that's focused on childcare centers. We have a program funded by HRSA that's focused on preventing death in Black babies before their first birthday. We have initiatives in reading and literacy in the schools. We have a child protection team. We've got a program going on right now with sexual trafficking and children who are in that. We have another with VOCA, the children exposed to violent crime. And then at a health equity level within our community, we're working with the county. We've spent a year talking about health equity for children, and the number one topic is safe, affordable housing for prevention of asthma, and making sure that children have access to nutritious food and places they can play safely. And it's this whole package that you've talked about with a whole lot of individual programs, each of which are doing a really good job, but how to tie them together and then how to disseminate that. We may pull it off here. I'm pretty confident that we're well along the way of putting all those pieces together. But then how do I move it to Tampa? How do I move it to Ocala? How do we move it to Central Kansas? Those are I think the challenges. I appreciate your thoughts on that. Unfortunately, I'm going to have to jump off because I got another Zoom call waiting. So I won't get to hear the talk. But just wanted to share that perspective because I do this to my faculty and staff all the time.
Thank you, Dr. Armstrong. Maita, what's our timing? We have about a minute or two, and then folks.
I think we just have a minute. Yeah.
All right, as quickly as I can. Where's the children's cabinet? Where's the children's cabinet in this country, right? Because the problem with early childhood is it's different than when kids hit 5. Then the public school system is like where you can put a bunch of this stuff. In early childhood, we have all these different sort of systems. So where's the children's cabinet for Miami-Dade, right? Where's the children's cabinet for Florida? And where's the children's cabinet for this country? Saying we have to braid all of this together and get it right. To your point about access and workforce, I couldn't agree more. The average mental health diagnosis for children, the last time I looked at the data, it's like around age 14, right? Symptoms started way before that. You know that, we know that. That kid who finally got an anxiety diagnosis at, sophomore year in high school was chewing on his shirt when you dropped him off for preschool and was the one who couldn't really join in the group setting. But we don't have the folks in those places to say, well, let's intervene now and let's teach coping skills and let's teach parents how to really navigate this system. I'm not Pollyanna-ish. We're still going to have kids with significant mental health concerns that are going to need to go to subspecialty services. But if we do a much better job up front, we will avoid some of them ever showing up in the first place, and we'll have kids who have more coping skills and a better platform to really make better choices throughout. But you and I could speak at length about both of those things, I think. And I'm going to send my children's cabinet piece that maybe she can share with you. But thank you for that excellent question.
Thank you.
Well, I think we're at the end of our time. Thank you so very much for joining us today and for sharing a little bit about the Healthy Steps program and all the wonderful work our specialists are doing across the country.
My absolute pleasure. Thank you for all the amazing work you're doing in Miami. Good to see some of you, and thank you for having me. Take good care.